Thank you very much again for your kind introduction. So I've been in Shanghai and in Fudan for a few days now, given several talks and lectures. So I'd like to say thank you very much again for inviting me to talk to you. And I'd like to say what a great experience it has been in many dimensions. So Shanghai, what a great city. And what great people I've met here. Some
听得清楚吗？
As I said in one of my earlier lectures, there's this link between Fudan and Cambridge. Cambridge is Britain's the West's top university. Fudan is the East's top university, so it is natural that we should link up. Anyway, so thank you very much indeed for your hospitality and intellectual engagement. So this is the third of the philosophy of medicine lectures. The first one, these are all to do really with, would you like me to?
Yeah.
Yeah, sure. Is that better? Is that working for you now? Good. What was I saying? The third of these lectures on philosophy of medicine, and the philosophy of medicine includes many things, and so I have been focusing only on a small slice of it, some epistemological problems in medicine. But so the first lecture was generally introducing a bit of history of medicine and why, in some sense, the epistemology of medicine is important. And I was proposing in the first lecture that it is important because the process of medicine becoming scientific was a slow one, and it's some people in the evidence-based medicine movement would say it's not quite complete, or it's only recently in history that we've got there, that the process of making medicine scientific has been a gradual one. But the question is, when did that start? And although one can, I think, see elements of science in medicine, in Western medicine going back over many centuries, and indeed one can find it in Eastern and Chinese medicine, what is distinctive about making something genuinely scientific is having a process, well-established epistemological processes or epistemic processes, well-established processes for making it probable or ensuring that what one believes is in fact true, for testing one's beliefs, and so in particular in medicine, for testing medical practices, medical interventions, to see that they actually do work in making people better, curing diseases, and so on, extending life, etc. So in the second lecture, I talked about how we would, one important process for doing that, the randomized controlled trial. But one of the questions I raised then was, and we discussed this, I think, in the discussion section, whether the randomized controlled trial is sufficient for knowledge in medicine, and also whether it's necessary. And the question of whether it's necessary is important because let's imagine that you could only get knowledge or reliable belief in medicine from a randomized controlled trial, then that might leave certain things unknowable. And that's what I'm interested in today, is those things that cannot be, for one reason or another, where we can't test them, we can't investigate theories and hypotheses in medicine through a randomized controlled trial. What do we do instead? Are there any ways of getting knowledge in medicine without doing a randomized controlled trial? So I'm going to introduce the idea of epidemiology and the need for what we will call observational studies in medicine. And we'll look at one point, two kinds of observational study, the case control study and the cohort study. And I'm going to look at a well-known and important paper by Austin Bradford Hill, in which he introduced what are called his criteria of causation, and then try and give some more general epistemological framework, or at least try and relate them to some more general epistemological ideas. Okay, so what is epidemiology? Well, I guess we've all had a bit too much epidemiology in recent years. But you might think epidemiology is the study of epidemics. And it does include that, but very much not only that. So it's more general. Here's some definitions. Epidemiology is the study of the determinants, occurrence, and distribution of health and disease in a population. Or possibly more simply, epidemiology is the study of how often diseases occur in different groups of people and why. And we're interested in, I think this is a nice simple definition, but we must, note that we're interested not only in disease, but health as well, or determinants of how often diseases occur or not occur, or anyway, we'll see what we mean. Oops, okay, how did that get now? So we're looking for causal relations. So these definitions are looking for explanations and causes, determinants of health and disease, why diseases occur. So that's explanations, causal explanations concerning disease and health in populations. So the techniques do include randomized controlled trials. That's one way of, can be one way of investigating how disease is present in a population. Laboratory studies, obviously important for understanding particular diseases. But what I'm particularly interested in today are observational studies, which are appropriate when a clinical trial is not appropriate, is not possible. So these are especially important in epidemiology. So when might it not be either appropriate or possible to investigate the causes of disease or causes of health and preventers of disease? So here are some examples of the sort of questions that epidemiology might be studying. Does exposure to asbestos cause cancer? Does social deprivation cause ill health? That's supposed to be or on the positive side. So I'm not sure how common this is in China, but in some parts of Europe, we put small amounts of fluoride in the water because that's thought to help people's teeth. Do you have that here?
We have that in toothpaste.
Oh, have it in the toothpaste, right. So you have it in toothpaste. So in some parts of Europe, it's just put into the water supply. But so that when you drink water from tap or whatever, then you get a little bit of fluoride. Some people think this is, some people are against this, right? Because they think this is giving people a medical treatment whether they want it or not. Other people say, it's good for the population as a whole, for children who don't have choices anyway. But yes, but it's important to know if you're doing it whether it's working. Okay. Does wearing a bicycle helmet reduce the risk of head injury? Interesting question. You might think it's obvious that it does, but there's some questions about whether this is really, in fact, the case. I'm sure that, oh yes. Does smoking cause lung cancer? Well, and we know the answer to that, but we didn't always know the answer to that, and how are we to find out? Here's an important one, studied by my colleagues at Bristol. Does putting babies to sleep on their backs reduce the incidence of sudden infant death syndrome? Yeah, it's a terrible outcome that you find little infants just die in their cots, in their cribs. And people have investigated what the best position for them to be put to sleep is, in terms of. So for some of these, it would be difficult or immoral to perform experiments, to perform a randomized controlled trial. So for example, in these cases, you might think the way that if you had no ethics at all, you were just interested in the scientific question, you might say, well, we will take some people, we'll have a randomized controlled trial, and some people will be allocated to the control group, no cigarettes, no smoking. The other people will be allocated to the smoking group, and they must smoke lots of cigarettes, right? But that's clearly unethical. But it's also actually rather different, even if it was not, even if you've, so I don't care about ethics, even if you said, even from a scientific point of view, it would be a difficult thing to do, partly because of the problems of, as I think I mentioned before, of compliance. It's very difficult to, some people just don't like cigarettes, right? And if they were in the experimental group, how would you make sure they were force them? How would you force them to smoke, right? Likewise, some people are addicted to cigarettes already, and if they were in the control group, how would you stop them? Typically, randomized controlled trials work quite well for diseases that are in hospitals and for a drug that you hope to have an effect quite quickly. But they're saying that these cases, we're not in hospitals, so you can't control what people are doing. And the effects of smoking on cancer typically take many years to see, right? Someone can be smoking for many years before they get cancer. So if you were to do this as a randomized controlled trial, it would also take a very long time. Okay. Possibly that would mean that you would delay the introduction of health measures because you say, I need another decade before I find out the results of my experiment, right? Okay, so there are reasons, ethical reasons, but also other reasons to do with sort of scientific reasons why it's difficult to carry out a randomized controlled trial for some studies, for some questions, to answer some questions. Okay. So what one can do is, you might think, well, what we have to do is look at people and what happens to them. So as we'll see, and in more detail, we'll look at smoking and cancer. Well, perhaps we should look at smokers and non-smokers and see whether smokers get lung cancer more frequently than non-smokers. But as you're all perfectly aware, it's not quite as simple as that. So when we are thinking in terms of observational studies, a typical target will be environmental causes of disease. Sometimes the environmental causes might be things over which individuals have some control, perhaps like smoking. You could call that in some sense an environmental cause of disease. But others are things over which people might have less control. Health problems caused by car exhaust fumes, for example, or industrial pollution generally, or, as we'll see now, diseases caused by specific exposures to do with the trades or professions that you're engaged with. So one of the very first studies of this kind was carried out by this guy, Bernardo Ramazzini, an Italian physician working at the end of the 17th, at the beginning of the 18th century, around 1700. So in the year 1700, he wrote this book in Latin, De Morbis Artificum Diatriba, a treatise on the illnesses or diseases. Artificum means of tradespeople, of artisans. And it was very soon after translated into English with a rather longer title. I think it's a rather neat title in Latin, but in English it's a treatise of the diseases of tradesmen, showing the various influences perhaps of particular trades upon the state of health, and so on and so forth. So here's a quotation from his book, at the beginning of his book. And he says, this is the English translation, "So runs the oracle of our inspired teacher. When you come to a patient's house," so this is he's quoting Hippocrates now. "When you come to a patient's house, you should ask him what sort of pains he had, what caused them, how many days he has been ill, and whether his bowels are working, and what sort of food he eats." And some of this is just sensible. This Hippocrates stuff, partly this is just sensible stuff that any doctor would want to know, but it's partly influenced by this humoral theory of disease of which I was talking earlier, because your humours, the balance of your humours are supposed to be influenced by your environment, your food, your activities, and so forth. But Ramazzini goes on to add, "So says Hippocrates in his work, The Affectations. I may venture to add one more question. What occupation does he follow? What profession, what trade does he engage in?" Okay, so and Ramazzini's book is a very interesting list of trades and the diseases. And one particular example of this was investigated by an English surgeon shortly afterwards, a guy called Percival Pott. This is the 18th century. And he looked at cancer of the scrotum, of the testes, or at least the testicular sac, in chimney sweeps. So he noticed that, so in European houses, you're made of your brick and stone, there would be they would keep them warm with fires in fireplaces. I guess I'm sure you've know what I'm talking about. So it'd just be coal or wood in a fireplace, and there'd be a chimney going up to and the smoke would go. But of course, the soot from the material from the smoke from these chimneys would build up soot inside the chimneys, and the chimneys needed to be cleaned every now and again. And this was done by sending small children up them to clean out all this soot. These children are known as chimney sweeps. They swept the chimneys. And these would be children, or they would do, not just small children, but children, indeed young teenagers, anybody who was small enough to go these constrained spaces. And it was a really unpleasant job, as you can imagine. And he describes how unpleasant it was, and he says, but in addition to being an uncomfortable and unpleasant job, was that they had that they had an uncommon incidence, very high incidence relative to the rest of the population, of this unpleasant cancerous disease. Because it was a disease associated, affecting one's reproductive organs, it was generally believed that it was a form of sexually transmitted disease, right? But he said, no, that doesn't make sense, right? Why would a sexually transmitted disease especially affect chimney sweeps? Right? I mean, that would be strange. It would be. No, it looks as if it has something to do with the occupation that they're involved in, and he speculated, and accurately as it turns out, that it had something to do with the accumulation of soot. You know what I mean by soot? The black smoky matter that's inside the chimneys, and on the skin of these chimney sweeps, in particular, in the scrotal area, where it's very difficult to get all the soot out. This was a period when people didn't have showers and so forth, and it's probably easier to get rid of the soot from the skin there than it was in all other parts of your body. Anyway, so he noticed and wrote about this connection. So, moving forward into the 20th century, this is a particularly important character we'll be coming back to again. Richard Dole. Dole, he went to my high school, a bit before me. Interesting, he was a socialist and was particularly interested in diseases that affected working people in factories and so forth, and how he could advise on reducing the chances of them being struck by disease. So he was the first to identify a connection between asbestos and lung diseases. So these days we're worried about older buildings that might have asbestos in them affecting ordinary people, but he started out by seeing the connection in people who worked with asbestos. There are many examples that he was interested in. He noticed that there was certain kinds of cancer, lung and nasal cancer, in certain metal refineries and so forth. So he made lots of these connections. But we're going to be talking about, possibly the most famous and perhaps important example, and that's the relation between smoking and cancer. Richard Doles, we will see, was particularly important in this, but there was some history of research into the relationship between smoking and cancer. And strange as it is, that some of the earliest research of this kind was done in Germany in the 1930s. This is a period of the Nazis. They were partly motivated by a sort of sense that sort of smoking was sort of genetically unclean and the rest of it. So oddly enough, they had the right idea about being anti-smoking, but they did associate it with some of their sort of more negative views about genetics and health and so forth. But actually, it turns out that some of the studies that they did were of at least scientifically high value, and these were observational studies. They were, so they in themselves they weren't unethical, even if some of the people behind them were. So I mean, this is a chart that we'll see another similar chart to this later. I mean, this is a chart it goes up to 1980, but what's interesting on this line here shows in Europe, I think, I'm not quite sure actually where the data comes from now. Cigarette consumption in men, and there's a 20-year lag with lung cancer rates. Now, in the 1940s, 30s, 40s, and 50s, we would have only had half of this graph, so that the tailing off in both wouldn't have seen this correlation. You just have seen the increase in both. So when you just see a big increase in two things, well, there's a nice correlation there, but of course, that proves very little. Right? If you just see an increase in both of these separated by 20 years, well, lots of things are increasing during this period. Not just cigarette consumption and lung cancer, but industrialization generally. City pollution generally increasing. So I'm sure there are many other things that we could draw that have this curve. And so the question is, why should we think that it's smoking that causes the lung cancer rather than anything else? And that's to me to the general problem, one of the general problems of observational studies. I mean, this is in some sense a piece of observation. It's just this is record of what people have been doing and what their diseases they've had. One statistician said, well, okay, there's a correlation here, and it may even be causal, but perhaps it is that, I mean, he wasn't looking at this chart in particular, but but at other data, and said, well, possibly it's that cancer causes people to smoke. So, well, they feel really bad and in their lungs, and therefore the smoking soothes their experience. Okay, so this guy Ernst Winder in the 1930s and 40s, with his colleague Graham, carried out some studies on smokers and non-smokers, and bronchial carcinoma, fancy word for lung cancer. You notice that so he split he studied both with cancer and people in hospital with other diseases, and noticed that non-smokers, there were very few non-smokers amongst the lung cancer sufferers, but many heavy smokers amongst them. But these proportions were not the same for the people suffering from other kinds of disease. So he was just looking at people in hospitals. I mean, it's important to note that the data on the left does not, if I showed you only the data on the left, that would tell you nothing, right, about the relationship between smoking and cancer. If I were just to tell you that we looked at lots of people with lung cancer, and many of them were heavy smokers, but only a few were non-smokers, that gives you no causal information. Why? Well, it could be that these figures here just tell you how many people smoke in the population in general, right? It might just tell you that of people in the population in general in 1940 or whenever it was, half of people are heavy smokers, right? And almost everybody else was a moderate smoker, and only a tiny number of people didn't smoke at all. And if that's true of the population in general, you would expect to find it in lung cancer if there's no causal connection. It's only the difference between this and this that suggests that there might be a causal connection. That's the important thing. And we will come back. This is an example of what we will call a case control study, and we'll come back to that in a moment. So although there were these quite good studies carried out in Germany and America, the really big sort of the studies that began to change people's behavior, the attitudes of governments and so forth, were two studies carried out by Richard Dole, whom I just mentioned, and Austin Bradford Hill, who I mentioned a couple of days ago. So they carried out these two studies, one in 1950 and then another a few years later. One is a case control study and the other is a cohort study. So a case control study is, as I said, Winder and Graham did this. We look at a particular population, and then we divide that population into those who have the disease and those who do not. And then we look to see whether the causal factor that we're interested in this case smoking, is more common amongst the cases of the disease in question, lung cancer, than in the controls, those who don't have it. And I think it's that they used a similar technique to Winder and Graham, which to look at people in hospitals, compare people in hospitals with lung cancer with people in hospitals without lung cancer. And I think they looked at people who had cancer but not lung cancer. Because you want your cases and controls to be as similar as possible, except for the thing that you're interested in. Okay, so I don't know why I've got this. Anyway, there's a fact for you. Okay, so they too had this. Yeah, so they too had this data that suggested that there was great increase both in smoking and in lung cancer. Yeah, so that was, as I said, that's not very strong evidence on its own, but it's why they were interested in looking in more detail. So they looked at various causes like that they considered: general atmospheric pollution and smoking. They thought that car exhaust fumes might be responsible. They thought that the laying of tarmac, laying of new roads. So roads in British cities previously had been made of what we call cobbles, or just stones. And then around this period, there was a lot of putting down modern road surfaces. But as you know, that can be quite a sort of smelly process. Fumes are given off, particularly when they were doing it then. They wondered whether those might be. But when they looked at the data, the smoking stood out as a possible, as much more correlated with lung disease than this. So for this, you can look at different levels of exposure, for example, by seeing whether people lived in cities or not versus people who live in the countryside and things like that. Okay, so in their study, they had they looked at similar numbers of people who had lung cancer as who didn't have lung cancer but had some other kind of cancer, and did that for men and for women. And then looked at whether they're smokers or non-smokers. So what we can see from this is, apart from anything else, so one thing you could see was how common smoking was in around 1950 in Britain, amongst men in particular. Even people who didn't have lung cancer, almost all of them were smokers compared to non-smokers, right? So in fact, actually, this is a real problem, okay, for collecting data, because you end up with actually very small numbers of non-smokers, and so it's quite difficult to do the comparison. I mean, put it this way, if everybody smoked, and they all smoked the same amount, it would be very difficult to tell that smoking causes cancer, right? Because everybody smokes. You couldn't make a distinction between those who smoke and those who don't and see whether lung cancer was more common amongst those who do smoke. In 1950, amongst men, smoking was so common, it was actually very difficult to carry out this kind of study, that you were almost in the situation that everybody did smoke. So actually the data is rather stronger amongst women, where smoking was somewhat less common. Still pretty common, but anyway, what we see is if you've got you've got similar numbers. In fact, exactly the same numbers of people with lung cancer, this is the men, and not with lung cancer, that lung cancer, hang on, let's do it this way. Yeah. You're much more that this shows that if these are the controls, these are people without lung cancer, that they are the ones who are not getting, are much more protected against lung cancer. Whereas if you had a lung cancer, you were extremely likely to be a smoker, but a little bit less likely if you didn't have lung cancer. The data, as I say, is clearer for women. So here's an important idea. They didn't just study whether people smoked or not, but they tried to find out how much they smoked. And so in fact, this is a rather good graph, because what we've got is we've got the same number of lung cancer patients and not lung cancer patients, same number. And so the white bars are not lung cancer, the black bars are lung cancer. And if smoking made no difference, then we would expect these bars to be the same throughout. Whether you smoked a little, or a medium amount, or a lot. If it made no difference, then these graphs, the black and white bars would be the same, and all this would show you is how common smoking is, heavy smoking, not smoking, and so on. But what we see is, if you smoke very little, or not at all rather, then you're much more likely to be non-lung cancer person. If you smoke a little bit, then you're still more likely to be a non-lung cancer person. Whereas if you smoke a lot, you're much more likely to be a cancer person than a non-cancer person. Okay. So this relationship is sometimes called a dose-response relationship, so that's the idea that the more of the exposure you have, the bigger dose you have, the bigger the response. So dose-response relationship. So this seems to show that not just that there's a correlation between smoking and lung cancer, but the more you smoke, the more likely you are to get cancer. Okay, a cohort study. So they just went into hospitals and looked at the smoker, looked at the lung cancer people, looked at the non-lung cancer people, and then found out whether they smoked or not, and how much. But this was a more sophisticated study that they carried out in the early 1950s, called a cohort study. And then what you do with a cohort study is you select a particular sample of a population, and then you gather data about them at various points over time. Indeed, some cohort studies have been going on for decades, and this was a cohort study done on British doctors. So don't worry about the data for the moment. The way this worked was that they got in touch they wrote to all British doctors, and then they said, we would like you to fill out this questionnaire telling us how much you smoke, information about how much they smoke. And they got a good response. And then they kept back checking every few years later after that to see which of these doctors were still alive, which had died, and if they died, what they died from. Okay, simple as that. And what they did was they looked at the deaths amongst these doctors, deaths from lung cancer. And they were able to predict the number of deaths that you would expect to see for different quantities of self-reported smoking. And they'd said that if you saw no connection between, if you thought that there was no connection between smoking and cancer, what we call remember we call this the null hypothesis. If the null hypothesis were true, then the distribution of deaths would follow the distribution according to quantity smoked, would be equal to the proportion of people who smoke in the population who smoke that amount. If half people are heavy smokers and there's no connection between smoking and death, then you'd expect half the people to have died. Yeah. So this is the expected deaths. if there's no connection. But what we in fact find is that none of the people who smoked none at all were dead a few years later, but twice as many people almost were amongst the heavy smokers than you would have expected. So again, that's a nice, strong dose-response relationship. And so we get this other chart here. This here is basically that data in a nice chart. So this just gives you the ratio between the observed and expected deaths. The ratio should be 1 if there's no connection. But you see there's this nice strong upward. They also noticed a connection, but a weaker one, between smoking and heart disease or heart attacks, which is interesting. Some, but very weak connection with other respiratory diseases. Here's the interesting thing, connection with other kinds of cancer. So I said they're looking at non-cancer patients. You might think, oh my goodness, smoking protects you against other kinds of cancer. Non-smokers are getting other kinds of cancer. So you better smoke if you want to prevent yourself from getting liver cancer or skin cancer and the rest of it. Why is that happening? What's going on here? Why is there this big... Why does it look as if smoking is protecting you, preventing you from getting other kinds of cancer?
Smoking dies early before other people.
Yeah. Smoking prevents you from getting liver cancer because it will kill you before you can get liver cancer. Exactly that. So, yeah, what are these things? You just present some of the data, it can be very misleading if I present that on its own. Yeah, exactly right. Yeah, that's right. Yeah, if I have a gun, I can prevent you all from getting cancer. Yeah. Okay. So later on, those two studies were the beginning of the long campaign against smoking, to dissuade people from smoking, to get governments to do things like ban advertising of smoking, to stop children from smoking, and so on, and so forth. And the cutting down of smoking has been, in countries that have adopted these measures, one of the most important reasons why people are living longer in countries that used to smoke a lot. I don't know how things are in China. I noticed that there's not much smoking in Shanghai. I haven't didn't see much. Is that people not smoke much in China anymore? Has that changed over time? Just curious.
It is forbidden to smoke in public spaces.
Yeah, right.
By law, but not all the people
Follow
this.
Right.
Yeah.
And is that a law that's been around for many years or quite recent? Okay, that's good. Over 10 years. Right. Yeah, interesting. So good. And yeah, it was nice to. Yeah, it's nice. I mean, it's sort of similar in Britain. But I remember when it changed. It was a big improvement in quality of life for everybody. But then it's strange. You go to countries where they don't have such laws, and you really notice. Anyway, good. So Austin Bradford Hill wrote an influential paper, much discussed a bit later, in which he talks about various criteria of causation, so-called, various things that you might look for in an observational study that would indicate, be a sign of causation between one thing and another, between an exposure and disease. So in most general terms, we can think what we're interested in is trying to prove the hypothesis that one thing causes another. But very generally, we've got an observed correlation. We've got an observed correlation between these two factors. And you say, oh yes, the one causes the other. Or at least that's a hypothesis that will occur to you. But we've got to consider alternative hypotheses. 3 of them. One is that, well, actually, just because there's a correlation, but it's the causation is the other way around. That there is a common cause. There's one thing that's causing both of these. And that's why they're correlated. And finally, it could be just an accident. There's simply no causal connection, but there's just a statistical artifact. Right. The second one is the one that we're most interested in and most difficult to, most obvious alternative. And that's the one that's called confounding. So how do we eliminate the possibility of a common cause? So you might get some evidence that is positive, confirming evidence of A causing B. You might have some, it might be, for example, just some, you might think, look, smoking, here's some evidence in favor of smoking causing cancer. You work out that cigarettes contain some substance, the tobacco contains some substance, and that substance you can show causes cancer in mice or something like that. And that you think, well, that strongly suggests that smoking might cause cancer in humans. And certainly will raise the probability, that sort of evidence. But it might not really be enough to really nail this hypothesis, to prove it. So in the previous lecture, I talked about inference to the best explanation and inference to the only explanation. And I think that what's going on, if you have positive evidence in this case, is that you're making this a better explanation than these other ones. I told you, well, actually, tobacco contains this substance, and if you feed them, if you give a lot of, paint a mouse with this substance, they get cancer. Then you might think, oh, well, that's strong evidence, but it doesn't eliminate these alternatives. You might think that this makes the hypothesis probable. But to really know that it's true, you need to eliminate the alternatives. So that's to say, to know that that's true, you need to find evidence that rules these other ones out, if you can. And Hill's criteria of causation, will help us to do that to some extent. And he mentions these criteria. Oh, I'm being slow again. I'll briefly mention what they are. So strength is the idea that if you've got a really strong correlation, that's in favour of your hypothesis. So, for example, John Snow, who I mentioned on Tuesday in connection with anaesthesia, he was also the father of epidemiology. So he carried out important studies in London in the middle of the 19th century to discover the route of transmission of cholera and the fact that it was transmitted through water, or being waterborne. And he did this important map of a certain area of London where there was lots of incidents of cholera. And this map is called a ghost map because these bars here represent deaths in particular locations. He found out where people lived who had died of cholera. And he noticed that the deaths from cholera were concentrated in a particular area and not elsewhere, near where there was a particular water pump. And this is a famous story that he had the pump handle removed so that people couldn't use it to prevent them from using that water and therefore getting cholera. But another bit of data that he collected, was that he said that there were two companies that supplied water to many of the homes in central London. One of which got, and they got the water from the river in different places. And it turned out that one of these companies, the mortality rate from cholera amongst its customers were much higher, almost 10 times higher, about 9 times higher than the other company. Right. But sometimes they even supplied the same street. The west side of the street had its water from one company, the east side from the other company, and if you lived on the west side, then you were more likely to die than on the east side. But this is highly suggestive data. It's strong data. Of course, it's strong data, but it's not conclusive data. I mentioned that some streets were supplied by both companies, but that's not true for all streets. After all, it could be that, on average, the parts of the city supplied by this company were poorer. Mostly poor households, mostly rich households. And that might be the explanation of the different death rates. Nothing to do with the quality of the water, but just the quality of the people, as it were. The health quality of the people to whom they supplied the water was different. So strength obviously favours this water hypothesis, but doesn't prove it. Percival Pott, he said, look, the relationship between scrotal cancer and chimney sweeps is so strong. This unusual cancer is found so frequently amongst chimney sweeps that it's difficult to imagine that there isn't some kind of causal relation. But the causal relation doesn't have to be from the chimney to the cancer. It's just that there is some kind of causal relation. Right? Okay, consistency is the idea that if you see the same relationship in different places at different times, then that strengthens the claim. But if you only see it in one place at one time, then that's less strong. Specificity is the idea that the evidence seems stronger when the disease and its hypothesized cause are quite specific. So again, being a chimney sweep and having scrotal cancer, those are quite specific things. It's not the same as, I don't know, being a labourer and getting cancer, which is much less specific. Another example was Richard Dole's working in this, his study of this nickel factory, nickel refinery, and nose cancer, very specific. Hill thinks that that's evidence. Temporality, well, this is simply the idea that causes precede their effects. So the fact that rise in smoking precedes the rise in cancer suggests that smoking causes cancer, not the other way around. Biological gradient, that's the thing I call the dose-response relationship. The more exposure, the more disease. We saw that with smoking. The more you smoke, the more likely cancer is. Plausibility, this chart shows us that. So this is the biological gradient, the fact that this ratio increases over with the ratio that shows how much more likely you are to get cancer than not. It increases with how much you smoke. Plausibility is the relationship plausible given other scientific knowledge that we have? So if you do have evidence that a substance in tobacco causes cancer in mice, that adds to the plausibility of the hypothesis that we're interested in. Coherence is much the same sort of thing. Is it excluded by any scientific knowledge that we have? So a problem. So this is a problem for homeopathy. The problem for homeopathy is that it seems not to cohere with what we know about causation in the physical sciences. The idea that a substance can cure you even if it's entirely pure water and has got nothing in it. How does that work? Seems not to cohere with what we know elsewhere. Experiment is, well, if you do carry out an RCT, that's jolly good. But then in some way, this shouldn't be on this list because what we're interested in is what you can learn from observational studies. But he's saying, but if you can do an experiment, that's good evidence. Analogy is just as it says, if there's some other kind of causal relationship that seems to be similar. So the fact that asbestos, if you've already shown that asbestos exposure causes lung cancer, then that seems to raise the probability that cigarette smoking might cause lung cancer. Because you know that lung cancer can be caused by breathing in a harmful substance. You think, well, we know that from asbestos, perhaps tobacco smoke is a harmful substance in the same way. So what we can do is think about these criteria and ask whether they help us with this problem of fixing the evidence to show that that's right and that these are wrong. So remember, what you want to do when you're making optimally, if you're making a causal inference, you are in this situation of having two comparative situations which differ only with respect to your putative cause and the putative and the outcome you're interested in. But the problem is, is this ever plausible in an observational study? If you look at the difference between smokers and non-smokers, is it plausible that the difference between smokers and non-smokers is only that the smokers smoke and the non-smokers don't smoke? Well, there could be all sorts of reasons why they differ in other respects. There might be there could also be all sorts of reasons that would persuade someone to smoke that might not in addition, so that it might depend upon. Or let's say that you people believed that smoking had not short-term but not lasting negative effects on athletic performance, say. People believed that. So it might be that people who are engaged in sports tend not to smoke. And so there would be this other difference between smokers and non-smokers. Not just that the smokers smoke and non-smokers don't, but the non-smokers are more likely to be engaged in athletic activity, just because of this belief that it's harmful it has a detrimental effect short term on athletic performance. But then there would be two differences between these two groups. There would be these people smoke and are less likely to engage in sport. These people don't smoke and are more likely to engage in sport. Now we've got two differences in what explains the lung cancer in one rather than the other. Okay, so that's so obviously, and we all know this, correlation is not causation. We can have a common cause. C is a common cause of A and B, so we can get a correlation without it being the case that A causes B. Okay, this is what we call the confounder or confounding variable factor. Okay, so here are some examples. HRT, that's hormone replacement therapy. So we're talking about middle-aged women going through the menopause. So a treatment that is offered to women going through the menopause, it can be quite uncomfortable. The menopause is to give them hormone replacement therapy. Is that a familiar idea? Yeah. Okay. Now it turned out that from observational studies that women in Britain and America who underwent hormone replacement therapy actually had a reduced chance of heart disease. And indeed, when doctors were discussing this possibility with their patients, they would say, look, here's a side advantage of undergoing hormone replacement therapy, is that it reduces your chance of heart disease as well. Win-win, right? Actually, that was what we get from an observational study, but later on, some years later, a randomized controlled trial was carried out, and it turned out that there was no reduced risk of heart disease. If anything, there was a statistically insignificant increase in the chances of heart disease. So why was there that difference? Well, I don't know how things are in China, but in Britain and America, because hormone replacement therapy was optional, it was much more likely, various reasons, to be offered to middle-class women than to working-class women. And it just so happens that middle-class women tended to have healthier lifestyles because of their occupations, because of cultural differences, because of being able to afford better food or being able to afford gym membership or whatever it is, that middle-class women tended to have healthier lifestyles, and therefore, because of those healthier lifestyles, had a reduced risk of heart disease. Right? So the hormone replacement therapy was not helping, doing anything with their hearts. It's just the fact that they were of their social class. Yeah, so this is, here's another example. Quite a nice example. It was observed that small children who were left to sleep with lights on in their bedrooms were more likely to have be short-sighted, myopic, have short sight. Okay. So it was thought that somehow that the light on in their rooms when they were small children, or babies or small children, was a cause of poor eyesight later on in life, or as they grew up, even as children. And it turns out that actually this again is a correlation without causation. It's because the parents had bad eyesight that they left the lights on because it was easier for them to see their children. Yeah. Okay. Yeah, and there's ongoing debates about different kinds of cholesterol and their relationship to heart disease in the similar kind of vein. Okay, so there are cases where we've got correlations, but we can't. It's not obvious that whether there's causation or not. So in all of these cases, one can think that if there's a correlation, it's a causal one because it sort of makes sense. But it's not. But one could easily think of alternative explanations of these correlations. At least in some of these cases. I mean, let's say you saw a correlation between wearing a cycle helmet and reduced risk of head injury. You might think it's obvious that it's the helmet that's protecting the individual. But actually, it's not immediately obvious that that's what's going on, because if it's an observational study, people are left to choose whether they wear a helmet or not. And you might think that the people who choose to wear a helmet are more cautious, more sensible. They're the ones that are cycling more slowly or looking out, or more carefully looking out for cars and so forth. And the people who say, "Oh, helmet, I don't care." They're also probably not looking out for. They're cycling more fast. They don't. They're not looking. They're willing to take risks. They run the red lights and so forth. So it might be that if there's a correlation between cycle helmet wearing and reduced risk of head injury, it's because helmet wearers are just risk averse and non-helmet wearers are risk takers. Right? And this is, oddly enough, this is still an open question. How much wearing a cycle helmet reduces head injury? I wear a cycle helmet, but I'm still not sure whether it does reduce head injury. I mean, I wore a helmet and I did end up in hospital with a head injury, and so anyway, who knows? One case doesn't prove anything. Okay, so but what we can do, sorry this has gone on so long, is, that's not, hang on, what's going on here? This is not right. Okay, sorry, I'll do this again. So, well, you can, I messed up this slide. Sorry. What I'm going to do is redo the slide. Okay, so what we can do is try and make sense of Hill's criteria of causation, and by asking ourselves, do they help us rule out the alternative hypotheses? Do they establish causation, A causes B, by ruling out these alternatives, B causes A, or there's a common cause, or there's no causal relation between them at all. So for example, the value of a strong correlation is that it makes it very much less likely and possibly, and perhaps in extreme cases, completely rules out the idea that it's just a mere accident, mere correlation. Okay. It doesn't necessarily rule out these ones. It doesn't. Yeah, this arrow ought to be a red arrow, or this means strength helps rule out this possibility. If you've got a very, very strong correlation, possibly the smoking and cancer is a good case. It suggests that it's not just an accident of chance that there's more lung cancer amongst smokers. It could be still, for all we know, that cancer causes smoking, or there's some common cause, genetic cause, that makes people both more likely to smoke and more likely to get cancer. Yeah. But the thought that it's just unconnected at all seems to be ruled out. Again, consistency, finding the same result over and over in different places and different times helps rule out the thought there's no causal relation. Specificity, I think, does the same. So many of these criteria just help establish that there's a causal connection of some sort, but without really pointing to which direction. Temporality, though, of course, is helpful, right? If we see a correlation and A always does precede B, then that helps rule out that B causing A. If it turns out that people always smoke before they get cancer rather than the other way around, then it rules out the thought that cancer causes smoking. Biological gradient, the thought that all this dose-response relationship, again, strengthens the idea that there's a genuine causal connection rather than just a random chance thing. It might... It's not obvious whether... I don't know. Sometimes I can persuade myself that it decreases the probability of a common cause, but it's not clear why that... I don't know why I say that. That's why it's very faint there. It reduces some possibility of some kinds of common cause, I think. I'm not sure about this. Coherence, well, that can rule out reverse causation. Experiment, well... experiment is the only... Doing a controlled trial can rule out the common cause, because it just cuts the possibility that there is a... if the distribution of the intervention, the cause, is random, then it can't be that there's a common cause of who gets the exposure and the outcome, if the exposure is determined randomly. So the experiment really does rule this one out. But the whole point is that if it's an observational study, then it's not an experiment. So we don't have that. Okay. So the point of this slide is really to point out that as long as you don't have experiment, it's very difficult to find evidence that A and B have a common cause. So what you have to do is to think really hard about what the possible common causes are, and then to find specific evidence that rules them out. So that you have to look to see whether when you control for the common cause, the possible common cause, whether you've still got the correlation. we would show that, so for example, we could rule out genetics as a common cause of, so this was proposed, perhaps genes make people both want to smoke and get cancer. All right. Well, how would you rule that out? Well, you might rule it out by seeing whether people who are genetically identical, that would be difficult, but if you could, if you do your study, you do your observational just on people with the same genes, if you still got a correlation between smoking and cancer, then you know that the genetic explanation is not right. But what that means is you have to think up individually all the possible common causes and then rule them out by looking at the data in that way. You can't, there's no general way of ruling out this common cause hypothesis. Anyway, so what that means is that observational studies are difficult to carry out and difficult to get a really convincing answer from. I'm not saying it's impossible, it's just very difficult. And you probably end up in a position where the data makes it the case that we think it's very plausible that there is causation, but we might not yet be in a position to say we know that there's causation. I think smoking and cancer is one case, but there are other cases where we're still unsure about, for example, exposure to what kinds of cholesterol and heart disease. There's still open questions. Well, we've got good data now, I think, but it's very difficult to carry out an observational study that is utterly conclusive. Okay, I think I better stop talking now. I've just gone on for far too long, and it's your chance to ask some questions. Sorry, I apologise for being so long. Sorry.